going to try to cover this in two parts. I'm firstly going to brush through as fast as possible through the information, the basics that you need to know. I'll be covering cardiac biomarkers and Lfts. Then, these are important topics that normally come in the essays in form of tables, sometimes comes in the sports in form of tables, sport exam. So I'll try to give you practice questions, 3 or 4. We try together. The first part, we'll try to brush through it as quickly as possible. Then the second part has to be interactive for you to understand. It's not a must you unmute. You can just type in the chat box. Okay, let's start. So we start with the cardiac biomarkers. So for a biomarker, from the name bio, it's just a biological, and marker, it's a marker. So it's a substance that is used to indicate a biological state. So for the heart, the cardiac biomarkers, the cardiac specific proteins that in the actin myosin, the regulatory proteins and enzymes. Okay, so the heart is normally made up of cardiac tissue that are striated. Then it's normally the pumping activity is by contraction and relaxation of the fibers. So since this heart is made up of cardiac specific proteins, the actin and myosin, the regulatory, we will see later that this actin and myosin is different from the one in the body. The regulatory proteins, the troponins also is different from the one in the body. There is the cardiac troponin I and the troponin T. Then the regulatory enzymes, you will see the new age and the old age, the regulatory proteins, the enzymes that are used in there as cardiac biomarkers. I remember last week I covered this part and I told you the ones that are important are the markers of necrosis, the second last point, the cardiac enzyme, the CKMB, the myoglobin, and the troponins. The myocardial stress, also a mark of heart failure. Remember, when the heart is failing, the heart is not able to pump, it is being overworked, it is choking on its own blood in a fail. So it is under stress. So the beta natriuretic type, you will also find in some boxes the A atrial natriuretic type peptide, the B, just depends. The B type was the one discovered in the brain, the A type was the one found in the atrium, different books. Also, last week you are told, or even today you will be told, the MI is an inflammatory process, the myocardial infarction. So the CRP, the C-reactive proteins are important. The others, markers of plaque rupture, ischemia, those ones you not find even in the wards, you will not see them. So the desirable features for the cardiac biomarkers, high sensitivity. What does that mean? By high sensitivity, it's like a small infarct, no matter how small it is, it picks up. No matter how small it is, it picks up. By high specificity, we will find things like, and it should be specific to that organ. You will find biomarkers like LDH, AST. LDH is also a mark of hemolysis. AST is part of the Lfts. ALP, which is also a cardiac biomarker, which is part of the Lfts, is also found in the bone. It is also found in the placenta. Rise and fall rapidly after ischemia. Yes, imagine a patient who gets an ischemia just close to the hospital and the cardiac biomarker starts to rise after 4 hours. Okay, if you do you take the panel for the cardiac biomarkers, negative. And that patient has undergone the cardiac event, but it's just that the biomarker has not yet peaked. So you understand what it means by rise and fall rapidly. Able to perform, those are basic points, able to perform reliably and uniform, be simple, have a high turnaround time. Like this one, I will come to cover it later. Like the time taken for the test to be done should be lower than the time for the ECG required. That is around 20 minutes. So it's less than 60 minutes. Not influenced by, and this is the same as high specificity. Like it should be specific to that organ, not found anywhere. Like you'll find also CK. CK is found in the skeletal muscle. It's found in the brain. It's found in the heart. So clinical utilization, what is this thing used for? It is used to check in the risks, diagnosis, prognosis. So before it happens, after, when it happens, you see it, and prognosis is or chances, and chances of goodness, and you take it like that. Like, is the prognosis good? Is the prognosis bad? And heart failure. I told you the BNP is a indicator of heart failure. So these are the old cardiac biomarkers, the CK, the AST, and the LDH. I told you the limitations, the poor specificity. So like AST is a Lft marker. AST is found in the skeletal muscle. The CK is found in the brain. It is found in the skeletal muscle. It is found in the heart. LDH is a mark of hemolysis. Also low sensitivity. I told you of the lag time between ischemia. So if you have like you have one here, I'm just there in the KNH ground floor. I get an MI, I'm taken to Ward 7C, do biomarkers, nothing, you will not find. So the CK is the most utilized enzyme in the evaluation of the MI. The other enzymes in the ST and LDH. I want you to look at the table, the onset, the peak hours, and the duration. Look at the duration for LDH. There's this MCQ that normally comes. A patient comes in after 7 days. Which one of the following is the most suitable cardiac biomarker? You see something like LDH and the troponins, they take time to cool off, and they remain in the system for long. So those are used for long-term management. And they're used to check cardiac events that happened long time ago because they are still in the bloodstream. I hope you understand by that point. They stay for long, so you can check for a MI or something, a cardiac event that happened around a week ago, 7 days. Troponin T goes up to 14 days. So these enzymes, they rise at different times. They are cleared at different times. I will show you a graph for that. So it is important to note when the blood sample is being taken. This is what I was telling you. The enzymes may rise up to 4 hours post-infarct. So what happens to the patient who had 1 hour and is just taken to the hospital? If the blood is drawn, it may give false negative results. So we cover them. We cover the 3 old ones, and we'll cover the troponins and the BNP. So I told you the CKMM is skeletal muscle, MB is cardiac, and BB is brain. So yeah, it peaks by 24 hours and is normal by day 3. CK and myoglobin, they rise quickly and they fall very quickly. So these are important. You remember the utilization I showed you. It is a risk factor. It is used for diagnosis, prognosis, and the and the HF. This CK and myoglobin and the troponins, which have very short times to peak, and they take 3 hours, troponins take 2 hours, they can be used to check for reperfusion injury, and they also can check for reinfarcts. So imagine I get an infarct now, then I get an infarct after like 5 hours. I'm at let's say 3 hours. So we need a biomarker that is going to rise, fall, then rise, then fall. So when you take my blood sample, you'll see 2 peaks. That shows there was a reperfusion injury or there was a ischemia. So they take, for the CK, remember this thing is also found in the skeletal muscle. So what if there's the intramuscular injection? What if there's a trauma? Yeah. So what if you're doing exercise? Remember, exercise, you break down your amino acid, then you reform. So what if there's a skeletal muscle injury? So for you to be specific, you need to take the ratio of the total CK to the CKMB for you to know. And the normal ratio is normally less than 6%. But in MI, the ratio of CKMB to CK is normally 10 to 30%. Then the AST and the LDH, these are now subsidiaries. Remember, I told you the main enzyme that is the CK long time ago, then AST and LDH are used to support. So this is found in the heart, the liver, the skeletal muscle. So in the patients with acute myocardial infarction, 2 to 3 days post-infarct, it is high. Then it is also a non-specific marker of hemolysis. Remember AST, hemolysis, LDH is the one that is used for hemolysis more, but AST is also an unspecific marker of hemolysis, and it is also a marker of Lfts. LDH, lactate dehydrogenase. The AST was aspartate aminotransferase. You can just say aspartate transaminase. I hope you remember the biochemistry from Dr. Mukuria. So it is widely distributed in the body. LDH is found in the heart, skeletal muscle, liver, kidney, brain, and RBC. That's what I was telling you. The LDH is a mark of hemolysis. Next week, I think you'll cover hemolytic anemias, and you will see the lab tests. You'll find LDH. There are 5 isoenzymes, the LDH 1 to 5. This is not important for now because you will still recover LDH on its own as a topic. The other biomarkers. Acute myocardial infarction is best measured after 4 to 7 days. That's what I was telling you. There's an MCQ that likes to come. Someone came after this number of days. Yes. So the value, this is what I was telling you. If a patient, like there's also this table that comes, what made the doctor do this and this test. So if a patient has typical clinical symptoms, chest pain, the patient has dyspnea, the patient has lower limb swelling for the heart failure, and has diagnostic ECG finding. What are the diagnostic ECG findings? The patient has the pathological Q wave, the ST elevation, the non-ST elevation, MIs. Then a cardiac enzyme profile is used to confirm. That means the symptoms, use the ECG, then you go to the biomarkers. Also useful in the reinfarction. The second elevation, I told you there will be 2 peaks in a reinfarction. Reperfusion injury, the one covering an patho will also tell you of the reperfusion injuries. Then there's the silent infarction. Remember, people with diabetes, they have sensory neuropathies. They're not going to feel that chest pain. Someone in a coma is not going to tell you, I'm having a chest pain, I'm having a dyspnea. So their MI, unless you do lab test, you're not even going to say. Someone can be having a major cardiac event and they're just lying there next to you. Especially this one in diabetes. You will come across it later in your clinical years, the silent reperfusion, the silent infarcts. These people have sensory neuropathy. That's why when they hit themselves on their feet, they will most likely not notice that injury, ending with things like diabetic foot and other things. So the current trend, this is what I was telling you. This is also part of the what is it called? Yeah, the markers of a good indicator that you had covered earlier. So there's no need to repeat. High sensitivity, high specificity, high turnaround. This one was the one I was telling you. The time required to complete must be about the same as that required to obtain an ECG. 20 minutes, you can say less than 60 minutes. Yeah, so the typical rise and fall, this is you do it with one of these. So the ischemic syndromes, the pathologic Q waves, the ST elevation. Remember the ST elevation myocardial infarction, the non-ST elevation myocardial infarction, the STEMI and the non-STEMI. This coronary artery intervention, leave it for now. Check the first 3. Look at the troponins, the duration. I want you to check the part for the duration. And the myoglobin, I want you to check the part for detection. You see the myoglobin, 1 hour, pop, it comes, it goes. Same as the CKMB. 3 hours, it comes, it goes. This one is very quick. Remember, the lactate dehydrogenase will take up to like 4. Let me show you so that you can take a comparison. You see, the lactate dehydrogenase takes up 12 hours, but it will stay for long. But myoglobin and CK, very quick, very fast. And the CK just disappears after 1 day. Look at the troponin T, goes up to 2 weeks. So post 2 weeks post-impact, you can just go back and cross-check. Did this happen? You go back. So from your physiology, the troponins have 3 subunits, the ICT, the I, the inhibitor, the T for the tropomyosin, and C for the calcium. The troponin T, troponin I, no big difference. There's no added advantage if you use both. One is okay. The But here for purposes of academia, we will learn both of them. So it is a cardiac muscle protein. This one's no one will ask you no one will ask you about this, but just learn for the troponin T and the troponin T, troponin I and T, and look at the abbreviation. This is how they're going to bring. No one is going to write for you cardiac troponin I in an exam. They'll just put for you CTNI, CTNT. The troponin T is also there. This was the peak I was telling you. Look at the troponin. There's the classic peak, the big peak. Can you see the big peak? Then there's the smaller peak for the microinfarct, the reinfarcts. So for the highly sensitive troponins, yeah, this one is just from the name, it's just highly sensitive, and it shows very, very small infarcts, the smallest one you can find. For now, this one we can leave it because we'll do it at the end. So for the natriuretic peptides, the heart secretes natriuretic peptides. This natriuretic peptide does the opposite of the RAS, the renin, angiotensin, aldosterone system. Remember, the RAS will act as a vasoconstrictor. The RAS will act as a what is an opposite of diuretic? So it will like try to conserve as much water as possible. It will try to conserve as much salt as possible by the aldosterone. It will hypertrophy the heart, the left ventricle. It will cause left ventricular hypertrophy. So this is the opposite. So remember, the RAS, its main function was to beef up the blood pressure. So this thing, it is to stabilize. And the RAS will do it will beef up the BP via conserving more water and constricting. So this one will do the opposite. So I told you in other texts, you'll find ANP, other BNP, just some out of academia. One was found in the atrium, one was found in the brain. So I told you it's the opposite, down-regulating remember the angiotensin. Yes, angiotensin will cause peripheral vascular resistance. Then the RAS will tell the sympathetic system to cause vasoconstriction. It will, so this one will be opposite. So this one will reduce the peripheral vascular resistance. It will down-regulate the vasoconstriction via the sympathetic nervous system. The smooth muscle relaxation that is responsible for vasoconstriction, it will reduce, so it will cause relaxation. Any opposite of RAS. Whatever renin-angiotensin does, this one does the opposite. It counters. This was what I was telling you. Remember, in heart failure, the person, I told you, the heart is choking in its own blood. And the heart is trying to pump, but it cannot pump. Other areas will be deprived of the oxygen nutrients. Like most of the heart go around the blood. Most of the blood is around the heart. So other areas, the heart cannot pump. It cannot pump towards other areas. So the heart chokes in its own blood, and the other areas do not receive blood. So the kidney, it will receive a little perfusion. So the kidney will say, like, maybe there's no blood. Let's put more blood. Conserves more water via the aldosterone, angiotensin, ADH. You see, so this one will do the opposite. So the BNP, this is the chemistry, literally, but the BNP is produced by, I told you, the RAS will try to conserve a lot of water. So what will happen? There's a lot of blood. So what will happen? This lot of blood will try to stretch the left ventricle. So the BNP is produced to counter that. That's why I'm telling you, that's the opposite of it. But this biological, no one will ask you that right now. So the utility, this one is it is a good negative predictive value. Has a high negative predictive value. What does that mean? It means that if it's there, you rule out. Yani, a negative result, rule out. But a positive result does not. If it is negative, there's no heart failure. And it rules out. You get, but a positive result does not rule in. I hope you understand by that. A negative result rules out. A positive result does not necessarily rule in. You have to do other tests. And the natriuretic peptides is used for heart failure. The other ones are used for ischemia. So like this table also, we will not cover it now. We will cover it on another time. We will cover it as a quiz in the end. So we are done with the biomarkers. Is there any question? Or I was speaking to my own. Any question for the biomarkers, the cardiac biomarkers? So let's assume there are none for now, but feel free to text in the, what's it called, the chat box, or even unmute. Here we are just, we are colleagues at Umezani. No one is going to swallow if you ask. So here I'm also going to cover like the important stuff, what you need to know. Need to know what will come in the exam. That one's, for now, it's not important. So like the functions of the liver, this one was being repeated from high school. The liver has almost 500 metabolic functions that you're not going to cover today. So the bilirubin is formed from hemoglobin and myoglobin, the globins. So it is, remember the bilirubin is not soluble in blood. So it needs to be transported via carrier protein, the albumin. So when it is transported, it goes to the hepatocyte, it is bound to ligands and Y protein. You can just imagine this in your head. It comes from the hemoglobin, then it is transported via albumin, the intracellular proteins, the Y ligands and the ligands and the Y protein receive it, they put it together with glucuronic acid. Then it moves via bile to the small intestine. This is just a process that you can imagine in your head. Then when it goes to the small intestine, it gets unconjugated, then it gets reduced into urobilinogen. Urobilinogen goes back to the photosystemic shunt. And you remember that, I don't know, it was not photosystemic shunt. There's that recycling. It comes, it goes, it returns, and there's a cycle that goes. Then some enters the systemic circulation and is excreted. So remember, it comes from via albumin, intracellular proteins, conjugate. I mean, this is an essay that I was fearing during my time that may come. So you need to focus here. So the liver function tests. Remember the function of the livers, the function of the liver. So the test is based on the excretory function. You can check for the bilirubin. What will bilirubin show? Bilirubin will bring jaundice, to bring things like itching. Remember the signs of LF, liver failure. You'll find itching. That's not for now, but you'll come across it later. So it will test for hepatocellular damage, the liver enzymes, which will come across the aminotransferase and the mark of cholestasis, the GGTP. So the test is also based on synthetic or storage function, the serum proteins and the blood glucose. The serum proteins, if there's liver damage, there's liver failure, you'll find things like albumin will be low. And that's why you find the patients with the liver failure when you come to the clinical years. Patients, or right now, I'm sure you are rotating the words. Patients with liver failure there in the pediatrics, they have swollen feet, they have a masaka, swollen body. It's because of this, the slow albumin will cause edema, peripheral limb swelling. You remember the oncotic and hydrostatic pressures, you went through them in physiology, you can still revise them. What low albumin will do to the periphery. Also, blood glucose. Remember, the liver is gluconeogenic, pro-glucose formation. So it's a normal question in the spot. We'll be given a table there, patient, it's hypoglycemic, it's below 3.2, we'll be given we'll learn about all those rotating in clinical chemistry, or actually you've learned about carbohydrate metabolism, the range for glucose. So you'll find it's below the lower range. So the LFT profile, this is a question that they bring in MCQs. Which one of the following is not among? Then they will put for you something there. So total bilirubin, both the conjugated and conjugated direct in bilirubin. This is the conjugated. Remember, the indirect bilirubin is not part of the LFT profile. You normally have to calculate by subtracting total from the direct. So the aminotransferase, that is the AST and the ALT, I told you what they were. Later, you can say aspartate transaminase. You can talk of aspartate aminotransferase. This also has GC. And those are basic biochemistry that you should be aware of right now. The alanine transaminase also has another name apart from alanine aminotransferase. The alkaline phosphatase, this one, I want you to be careful with it because they like asking in the exam. They will tell you the patient has a normal liver, has a normal everything, but they have a bone problem. Remember, alkaline phosphatase is also found in the bone. Whenever a person is growing, growth spurts will come when you do bone metabolism or bone pathology. Will come across this thing. Patient is growing, you will expect it to rise. They'll have a normal liver, but the LP is raised. The gamma glutamyl transferase is a marker of cholestasis. The albumin, the bile acids. So I told you the indirect bilirubin is not part of the LFT. You'll calculate it on its own. So this biochemical test, remember, if you see someone with yellow eyes, most likely bilirubin is elevated. You will do an LFT profile. Remember, some drugs, most drugs, the anti-TB drugs especially, you will also find in your MCQs, which one of the following anti-TB drugs does not cause hepatotoxicity? Most of them cause hepatotoxicity apart from one. You will go and read on your own that one. Go through the slides. The monitoring of alcoholism. Remember, the alcohol kills the liver, it eats the liver, causes a fatty liver disease. Apart from the hepatocellular carcinoma and other things. Then jaundice, there is yellow discoloration. Normally, it's detectable when the levels are 40. So this jaundice is divided into three. The prehepatic. Prehepatic is normally due to hemolysis. Remember, the hemoglobin is being formed a lot. So the hepatic, there's a problem with the metabolism. Remember, the liver has 500 metabolic function. Among them is the metabolism of bilirubin. So there's a problem with the metabolism impaired. Then there's a post-hepatic. This is the problem with excretion. So we divide them into two, the unconjugated and the conjugated. So unconjugated is normally because of hemolysis. The unconjugated is because of reduced binding of bilirubin to albumin. Then there's this very unique disease, the Gilbert syndrome, the lack of the conjugative enzymes. So remember, the bilirubin comes from hemoglobin and myoglobin, then comes by albumin, then it is received by the intracellular proteins by the ligands and the Y proteins, then it is conjugated. So this conjugating enzymes, the one that conjugates this one with glucuronic acid, it's absent. So you'll get a syndrome known as Gilbert syndrome. But for now, just cram this hemolysis, just not cram, hemolysis of hemolysis and Gilbert syndrome that will cause it. Also, this table, just ignore the tables for now because we'll cover them at the end. So for the conjugated, is normal obstruction. This is cholestasis. These are markers of cholestasis, the ALP and the GGT, gamma glutamine transferase. I want you to point out of the neonatal hyperbilirubinemia in the neonates. You'll find a child that is born with jaundice. So what will happen to this child? There's something, you are not right now rotating in pediatrics, the blue light therapy, whereby they're exposed to blue light. Then it reduces to up to 50% in an hour. That is normally the unconjugated, the one that I told you, hemolysis and lack of conjugating enzymes. These metabolic diseases, the enzymes and the other things, they are mostly found in the neonates and the pediatric population. So we covered the aminotransferases, the AST and the ALT. Here, there's nothing much you need to know. Just know that the AST and the LT are markers of liver injury. The AST to ALT ratio, if the AST is twice to the LT, it's a marker of cirrhosis. The LT is more than AST, it's a marker of hepatitis or any other liver injury. So the AST is found in, I told you, it's found in the heart, it's found in the liver. Remember, cardiac biomarkers you were covering, the ALT is found in the liver, kidneys mainly. The AST is both cytoplasmic and mitochondrial. The ALT is cytoplasmic. That's an MCQ question, Apple. The alkaline phosphatase, I insisted. Remember, the kidney, it's found in the kidney, it's found in the bone. The bone, this is a question that I've seen severally. So cholestasis simulates ALP by hepatocytes. These are markers of cholestasis. Gamma glutamyl transferase is also a marker of cholestasis, but it is more sensitive than ALP. Remember, this one is the more sensitive part, the GGT. This, I want you guys to focus in this table. I want you to look at the second point under the parameters, the bilirubin functions for the hemolytic, for the hepatic, and the cholestasis. That is the pre-hepatic, hepatic, and post-hepatic. Look at the bilirubin fractions. So for the hemolytic, it's normally unconjugated. For the hepatic, everything is mixed, normal. But I want you to focus on the hemolytic. We make differences between the hemolytic and cholestasis. Because this is a common question, you'll be told, describe the urinary function, the urinary findings, what will you find here, what will you find there. So the bilirubin fractions in the hemolytic is unconjugated, but in cholestasis is conjugated. The AST to AST, ALT, that is not a ratio, that's not dividing, it just tells you ALT or AST is this. So for the hemolytic, the AST, the aminotransferases will be raised, but in the cholestasis, it will be mild. Remember, when obstruction, it can be reversed. The obstruction in the biliary tree, it may leak in the biliary tree, it may cause injury on the back end, a reversal. I hope you can imagine this. There's a liver, it has this bile ducts, there's obstruction there along the cystic ducts, then the injury, it leaks there, then it comes and causes damage on the liver. And if there's a back leak and causes of damage. The ALP and the GGT is marked in cholestasis, but is normal in hemolysis. The haptoglobulin and hemopexin, these are MOPAP proteins of hemolysis. So you'll find in the hemolysis, hemolytic, these are MOPAPs. Imagine this hemolysis will create a mess. So the haptoglobulin and the hemopexin, these are regulatory proteins. They come the MOPAP and get used in that process of cleaning up hemolysis. So they'll be low. You'll be asked of laboratory findings in hemolysis in your hematology. The way they like asking. Remember, hemopexin and the haptoglobulin is consumed in hemolysis, and it will be low. Cholestasis, it will be normal. This was the part that I was telling you now. The urine and stool. This is a question that normally comes. The urinary findings in hemolysis, the urobilinogen. Then in cholestasis, you will find there is bilirubin in urine. You will find Coca-Cola colored urine. Patient tells you, I am urinating color black or color chai or color kahawa. That is obstructive jaundice. Stool color in obstructive jaundice, it is pale. It is pale color. You see that KNH, those KNH word tiles. Go look at them tomorrow or on Monday, ukienda. That ashy colored pale tiles. They will tell you, they will point to you that tile, then they will tell you inakaa hivi. So in cholestasis, Coca-Cola colored urine, and there's pale stools. This one you'll find hemopexin is low, and yes, hemopexin is low, hepatoglobulin is low, and there's urobilinogen. Hemolysis, it is unconjugated. This one is conjugated. Hemolysis, the AST and LT, this one will be GGT and ALP. We are almost finishing the content bit. So there's hepatic injury, acute or chronic. The cutoff for this thing is 6 months. So it is acute for as long as it is 6 months and below. It is chronic for as long as it is 6 months and above. The acute is hepatitis. Remember, you cannot get the hepatitis, for example, like hepatitis E, that is supposed to come and clear. Hepatitis A has no residual effect. It either comes and it clears, but B and C can progress to hepatocellular carcinoma. Also D, hepatitis. I did my biology and microbiology, so I do not need to reteach. So this is not necessary for now. This table, I will tell you, we will redo it. But I want you to check the 40-year-old female in the far right. In the far right. This one you'll do on your own free time. The 40-year-old female at the far right. The one that has CA125. CA125 is a marker of, is a tumor marker. So if there's a malignancy most of the time it causes obstruction. So what if there's an obstruction? What are you expected to see? So for the chronic hepatic injury, cirrhosis and hepatocellular carcinoma. Remember, it is more than 6 months. More than 6 months. I was telling you for the AST to LT ratio, AST has to be twice. AST is normally twice the LT, or you can say the ratio is greater than 1. Remember, the liver, it is damaged, liver failure. The cirrhosis is causing liver failure, so there will be low albumin. That's why I'm telling you, patients with the cirrhosis, liver failure, they will have ascites, fluid in the abdomen. They will have lower limb swelling. They will have fluid in their face, and everywhere they will be. This patient will be having fluids and everywhere. Also, the alpha fetoprotein. You will have a lecture on tumor markers, but just know that the alpha fetoprotein is for the liver, the chorioembryonic antigen, CEA. The chorioembryonic antigen is for the colorectal area, the colon and the rectal area. Then the others like CA125 or the C19-9. So we go to the functions of the bile acids. Here, just this function of the bile acid, just play around with cholesterol, lipids, phospholipids, the fat-soluble vitamins, then the fatty things that deal with our diet. You learned that cholesterol is important. I'm talking of the second point. This is the most important here because it will bring about a disease, not actually a disease, a scenario referred to as cholestasis. Like the cholesterol is used to solubilize, the bile salts is used to make the cholesterol more soluble. Remember, it's insoluble. So if the cholesterol is more than the bile salts, it will crystallize and bring that cholestasis. Yeah, that one. So the synthesis, yeah. So remember, you just play around with the fat soluble vitamins, the lipids, the triglycerides, and they're used in the metabolism and digestion of that. So you can have several points there. Also remember, the bile acids is a method whereby the cholesterol, the excess is being excreted. Also, it controls liver cell regeneration. So these slides are available to you. You can easily go through them. But remember, they play around with your dietary lipids, triglycerides, phospholipids, the fat-soluble vitamins, the vitamin A, B, K, E, cholesterol, solubilize and excrete them. Those are around 5-6 points. So we are done with the content part. I would like us to go to the assignments bit, and we just do 2-3 questions. Then we call it a day. So any questions, anything? I'm seeing there's one in the chat box. Oh, the part for troponin. Okay, no problem. No problem, no problem. So troponin, kuna troponin I, C, and T. The troponin I is the inhibitor. Troponin C is the one that deals with calcium. Troponin T, wait, we reach to it. Troponin T is the one that binds to tropomyosin. Which part of the troponin is equal? Give me 1 minute. Yeah. What exactly about the troponins you didn't understand? The one that I was telling you, there's this MCQ that normally comes. A patient comes in after this number of days. Remember, the troponin and the lactase dehydrogenase will stay for long periods. So if it stays for long periods in your bloodstream, it can be detected. Troponin T Troponin T can stay up, will start returning to normal after 14 days. You see the last part, it peaks between 12 to 96 hours. That's not important, but I want you to know the time it is still found. So after 14 days, it is still there. Also remember the creatine kinase, myoglobin, and troponins. These three enzymes, they are seen very quickly. They are seen very quickly. So after like 3 hours, 2 hours, especially for troponin that has a half-life of 2 hours, you see the half-life of cardiac troponin I, the second last point, is 2 to 4 hours. So in a sharp peak, it has already started to go through in half. That's what it means by half-life. So it has already peaked na ishaanza kushuka. That's why it's there. So these are used for reperfusion injuries. There was this graph I was showing you. I don't know if it's here. It's down. Yeah, this one. You see troponin, the big graph, the big spike has troponin. Also, the reinfarct has troponin. The big spike has troponin and the lower spike has troponin. That is for the reinfarction injury. So is there any questions, anything? So we go to the assignments. I want this assignment part to be as interactive as possible, okay? I want us to attempt question 2. The biochemistry results for that 57-year-old hypertensive. That hypertensive man who was admitted with a diagnosis of COVID-19. The diagnosis for the infection is made by PCR method. So that's the table with the reference ranges. Yeah, first of all, I want someone to interpret these results. Kindly, you can just type in the chat box, someone to interpret those results. It's not difficult, just a matter of saying. Remember I told you last week, interpretation, you just say what you see. So who is now the problem is I cannot see who is in the chat. Interpretation, guys, it's just about seeing. You just look at it, then you say this one is raised, this one is low. Yeah, the ALT is raised. Yes. What about AST? Is it normal? This one, you just say it like that. ALT is raised, yes. The AST is also raised. The LDH is also raised. The total CK is also raised. The CKMB, and everything is raised here. So why the reasons why the doctor requested for these results? Reasons why the doctor requested for these results. I told you there were three things that go hand in hand. And I even remember ruling out the last one. The coronary intervention, I told you that one, leave it for now. So two possible reasons why the doctor requested for these results. You can just type in the chat box. Okay, that's a little bit serious, but not, yeah, it can be for diagnosis, prognosis, but not exactly that one. Remember this one, this was the slide I'm talking about. One minute, so that you can see hizi maswali zinatoka kutoka slides. Here it is. So clinical signs and symptoms. They have diagnostic ECG. So that is what will push the doctor now to do the third one, that is the cardiac biomarkers. So possible reasons why this doctor made this patient to do. So they were having signs and symptoms of MI. They were having chest pain. They were having dyspnea. They were having retrosternal chest pain. They are having things like signs and symptoms. Look at PNB, heart failure. It's a mark of heart failure. So this patient is maybe having also trouble breathing. Remember when the fluid goes in the lungs, trouble breathing. This patient may be having signs and symptoms of heart failure, swollen limbs, akona lower limb swelling. Okay, so that is for that. So you can talk of signs and symptoms of MI, signs and symptoms of HF. You can also talk, maybe the patient had suggestive ECG findings that push the doctor to do the biomarkers, the pathologic Q waves, the ST elevation. Okay, so describe the second one. What was the difference between CK and CKMB? I told you of this difference. You can just type kwenye chat box. It's simple questions, this one that you have covered before. So for the CK is total. CK for the CKMM for the skeletal muscle, the CKMB for the heart, and the CKBB for the brain. But the CKMB is the one found in the heart. So that is the difference. And it's just as simple as that. Yes. CKMB is specific to myocardium, and the CK is total for everything, the heart, the brain, and the myocardium. So provide a possible explanation for the difference between ALT and AST results. ALT and AST. Why is the AST widely marked than the ALT? Look at the ALT, that's there's a increase, but the AST is a marked increase. Why? Why so? Why is the AST widely marked? So I remember telling you the AST is found in the liver, it is found in the heart, it is found in skeletal muscle and other, yeah. Okay, so no need reply. Yeah, so it is found in the liver, the heart, the skeletal muscle. So this patient is having, the results are suggestive of an MI. So this patient, this AST is coming from the heart. It is not coming from another place, it is from the heart. The LT is mostly in the liver and other areas. That's why it's just a marked increase. But this marked increase is from the AST. The AST elevation is from the cardiac muscle. We may understand why that's highly marked, even though it's a part of the LFT profile. It is also a cardiac biomarker, and this patient is having a cardiac event, so the AST level is observed to be marked. So possible explanation for the LDH mark rise. It's just the same as what I was telling you for the AST. Let's just simply put, it's like the one for the AST. This patient is having a cardiac event, so the LDH is also observed to be rising. Just simple as that. No, haina complication mingi. So giving the diagnosis, giving reasons, provide a possible diagnosis. Here is where now I want your input. I will not let this slide. Nitawacha you say, what are the possible diagnoses from the table? Because I've interpreted for you, I've answered the questions for you, but this one you need to, it will tell me at least you've learned something from that cardiac biomarkers. So possible diagnosis, you can easily just type it. Yes, acute MI. That is one. Look at the pro-BNP, the B natriuretic type peptide. Do not underestimate that and ignore. This question has 3 marks. The MI nimekubaliana nayo because this cardiac biomarkers are elevated. Look at the BNP. I said it's a mark of something. Yeah, secondary to HF. Good, good, good. So we are done with this one. I want us to cover this one. And this one, okay, we can cover this one because the first one you guys were silent. We'll cover this one, then we'll do one more for Lfts, then we'll call it a day. So the following results were obtained from a 65-year-old female diabetic who is presented with general weakness and fatigue. Remember, this one is a diabetic. So the NT-PNB elevated. I wanted to do this one. This question is also found in the slides, a similar one to it. The highly sensitive troponin I is 52. The highly sensitive troponin I on the next day is 60.6. Interpretation. Kindly someone interpret. Interpretation should be the easiest. These are the marks. No one is supposed to miss them. It's just seeing and writing. You do not even have to have content. A high schooler can interpret. I'm still waiting. Just say this is yes. The BNP is raised, yes. What about the troponins? Yeah, that one nimekubaliana nayo, the BNP is raised. The natriuretic peptides. The natriuretic peptides there are okay. What about the troponin? Troponins, yeah. Troponins are not, yani it is there. It is not supposed to be seen there, but it is there, but it's not highly efficacious or cut-off range to call an MI. Yani the highly sensitive troponin measures, yani small, in fact, it measures, okay? But it has not reached the cut-off point to call it an MI. So you can see it should be less than 100. If it's above 100, we call it an MI, or the between type 1 and type 2 should be more than 10. This one has not reached 10. But remember, the highly sensitive troponin measures small effects. So what is highly sensitive troponin? That is a definition question that I've already talked about. What is anti-BNP used for? I was just answering that, Paliju. What is it used for? Yeah, it's an indicator for heart failure. Good. So what are the possible explanation for the troponin results? I've explained it in a way, so if you got the gist of it, you can easily explain here. What is the explanation for the troponin? It is there, but it's not reached the cutoff points. But remember, it's an indication of something when it's there. Not diagnosis, but indicator of risk. Not really, not really. This thing is there, but it's not yet reached cutoff point. It's like those rides that have a height limit. The person is there wanting to go on the ride, but they have not yet reached that height. You cannot say the person is not there, and that person is an indicator of something. Eh? So why is it there? But hmm? Yeah, you can say like yeah, there is a minor impact. Ah, that's perfect. That's perfect. There's a minor impact. That's good. Also, what is the likely diagnosis? Minor impacts give reason. The highly sensitive troponin is there. It was read. It was found, even though it is not it's not reached the lower range to call it an MI, but there's a minor impact. Describe two other conditions that may lead to similar results. After the anatpatho lecture that will be covered by Abdurrahman, I'm sure you will have several answers to give. Things that can bring the ischemia, eh? Things that can bring heart failure. You will have several answers. So that one is more of homework for you. LFTs, I'll just do one question. I will do number 3. Number 4, I will give you a chance to take a screenshot and you answer. So the following serum results were obtained for a 69-year-old man. Interpretation, I will not ask you because I've come to understand that no one wants to answer interpretation question, but it's the simplest thing you'll come across in med school. It is just like looking for pallor. Classify the type of jaundice. So someone classify the type of jaundice. classify the type of jaundice. This is simple. It's just a matter of looking and seeing. I told you the direct is going to tell you this, the indirect is going to say this. You can see the direct is elevated. So the direct is going to tell you which type of jaundice. Is it conjugated? Is it unconjugated? Is it mixed? Huh? Just the type of jaundice. Not the diagnosis has been asked. You're just told the type of jaundice. Is it conjugated? Is it unconjugated? Remember, types of hyperbilirubinemia. It is either conjugated or unconjugated hyperbilirubinemia. Wait, here it is. Yeah, jaundice. It's either conjugated or unconjugated. So which type of jaundice? So let me just say, you see the indirect is unconjugated, mainly from hemolysis, mainly from lack of, yeah, conjugated, that's correct. The direct is a mark of conjugated. This is obstruction. That is perfect, Kapsa. So the two possible causes of this type of jaundice, remember it is a marker of obstruction. And I told you about the CA121. Yeah? So possible causes of obstruction. Eh? Let's put it like this. What if there's a stone? Last week you talked gallstones. Yeah, good. This was exactly what I was about to say. There's a gallstone and there's a tumor. Tumor can be from anywhere along the GIT. It can be even the tumor itself for the gallbladder. It can be tumor from the liver that is compressing along the tree. And these tumors, you can just fix any tumor there. You can talk of the pancreas, you can talk of the gallbladder, the cholangiocarcinoma that is causing obstruction, the hepatocellular that is going to cause obstruction, along the biliary tree, then the gallstones, pain point. But this one is a 69-year-old man. If that was not written there, remember biliary atresia huwezi pata kwa this person with this age. So 69-year-old man rules out biliary atresia. Provide a possible explanation for the low calcium. Why is the calcium like that? Why is the calcium like that? I'm sure Dr. Mubegi talked of vitamin D metabolism and calcium metabolism in second year. And right now, those content is fresh, just from finishing biochemistry. Why is the calcium like that? And I've told you that you have learned of vitamin D metabolism. So you should get the gist of how it goes. How does calcium and liver and vitamin D go hand in hand? Someone just try. We are all colleagues here. No one is going to beat the other one. Just try. You can try. Anyone who wants to try? It's part of vitamin D metabolism. You remember the 25 hydroxylation of cholecalciferol, the vitamin D? The liver does 25 hydroxylation. The kidney goes and does 125, so it becomes 125 dihydrocholecalciferol or 125 vitamin D. Remember that point. So if the liver is damaged, there's no 25 hydroxylation. There is no 25 hydroxylation, meaning that vitamin D is not going to be formed. And remember, vitamin D is important for calcium metabolism, calcium absorption. So the calcium is going to be low. Okay? So giving reasons, list 2 additional biochemical tests which will be useful for this patient. Just from talking about alpha fetoprotein. The alpha fetoprotein can be used here. It's a tumor marker. Also, you can check for cause of this. Cause of this, you can check for serology for hepatitis. Why is the ALT, the AST elevated? You can check for that. Other tests, remember I told you of the albumin that will cause swelling, the lower limb, fluid retention. You can check for the electrolyte panel, the different electrolytes. Remember the liver, its function is for bile salt, so you can check the bile acids. You can look for the glucose. Remember I told you the gluconeogenesis in the liver. These are things that I mentioned. The urea, creatinine. Remember the urea metabolism into ammonia. It's done in the liver. You can check for the urea levels and other things like that. Remember the tumor markers, alpha fetoprotein, the CA125, things that can cause obstruction. The CEA cannot apply. CEA is a marker of general GI tumors, but more specific for colorectal. You can also put it here, kama imeshindikana, like points are down and the marks are high. You get that situation, 4 marks, you have 2 points. You can fix CEA here. I think that will be all. This one, you can just take a screenshot here. You put it for homework. Remember, this is a COVID question. I easily come in your exam. They brought for you a COVID one in immunology. Why not put it for clinical chemistry? Classify the type of jaundice. This one I told you. Non-infectious causes. This one can be easy. Describe 2 mechanisms which COVID can cause hepatic injury. When you see such a question here, just remember direct attack by the virus, or it can be because of the drugs that are used. You can remember the drugs used for COVID. What does the low albumin suggest? That is could be easy. And what will the low albumin result in? The sign that will remember there's a difference between sign and symptom. The sign that it will show. What are the expected serum electrolytes findings? Give reasons. And that will be all. That will be all. So you screenshot this. On question E. Okay, question E, I've seen this question severally in the sport exam. Screenshot in my pair 30 seconds because you've refused to answer. You screenshot, then you put on your own. After say at the end of the day, I will share for you these 2 PDFs for the Lfts and cardiac biomarkers with answers.